heard lots that actually have crossover between the first workshop and the second workshop, but we're going to focus in a little bit more detail on some of the service redesign, clinical engagement and change management issues that a couple of case study sites from Scotland, first of all, with Michelle Brogan from NHS24, and secondly with Vantja Tangine from southern Norway. And then I'm going to give a short sort of summary, perhaps, of some of the issues around service redesign, clinical engagement and change management that, from a more theoretical perspective, to perhaps, how can I say, comfort us that perhaps some of the learning that we're having, some of the pain that we're going through within United for Health and some of our other activities isn't a surprise, and just keep doing what we're doing. Keep at it and keep sort of taking the pain-killing tablets. Okay, so welcome, Michelle, for the first presentation.
Hello, thank you very much for the introduction. So I am Programme Manager for United for Health in Scotland, and we are participating in all three real pilots for United for Health. But today I'm really going to share with you some key lessons around our work with the diabetes workstream. I thought it would be more helpful to target in one specific area so we can drill down to more detail. So just to set the context, and a little about the healthcare landscape in Scotland. So here we have a map of Scotland, and you can really see I've identified where our United for Health partners are located. Scotland is split into 14 health and social care integrated partnerships. So we have 14 different areas which have operational, financial responsibilities for delivering healthcare within that locality. United for Health are represented in 3 of these. So we are starting small with a big vision to roll out. Also within the 14 health boards, we have special health boards, and that is what NHS24, Scottish Centre for Telehealth, is classified as. So we have a national remit in order to take forward national programmes. So essentially our funding within NHS Scotland is from public spending, and it's free at the point of delivery. And we have, you can see really from the map, the geographical challenges. We have everything. We have remote, rural, and we have some urban areas. And actually, quite interestingly, the partners for United for Health represent all of those areas. So we have Glasgow, which is an urban city in Scotland. We have Lanarkshire, which is much more remote and rural, and Ayrshire, which is more remote and rural. So we have them captured. In terms of the demographics, we have a population of around about 5.3 million people. Scottish Government statistics tell us that 1 million of those people have a long-term condition, and with adults in Scotland, 42% of them have a limited or non-limited limiting life long-term condition. So we do have additional areas of deprivation and ageing population challenges as other countries in Europe, and probably quite interestingly for United for Health, in terms of clinical diagnosis, we have a 14.9% of the population have some cardiovascular clinical conditions, 3.8% for COPD, and 5.2% for diabetes. So quite high numbers for Scotland. So perhaps just to set the context around the change, the technological change that we're implementing with United for Health. So what you see here is a database. It's a clinical platform or portal that all of the clinical services in Scotland use. Everyone who's involved in hospital care for diabetes, everyone GP services, primary care services, all use this clinical platform for reporting and recording clinical data for people with diabetes. So you can see an example of what it looks like. And also the other side, you can see how it integrates with a whole range of other sub-systems and data centres in Scotland. And it's really been an excellent achievement for Scotland to achieve that. And it really does create that centralisation of data and patient information. Secondly, we have in Scotland, from a user perspective, we have an interactive website called My Diabetes My Way. And this really is almost like hub of information for people with diabetes. You can see here the list of the contents that it has. It quite clearly already links with Sky DC, the previous slide, but currently at the moment you're only allowed a manual upload of your blood glucose monitor readings, so there's no automated or digital process there at all. This received numerous awards really because it's free for patients to access and it's fully interactive and really provides a real platform for self-monitoring of this condition in Scotland. So what are we doing in United for Health? Well, essentially we're bringing these two components together. We're bringing together, from a user perspective, My Diabetes My Way, linking it with Sky Diabetes, which is the clinical interface, and we're using a software called Diasend, and Diasend will be used to enable patients at home to digitally upload their readings, and with that the information be shared across My Diabetes My Way, and also for clinicians through Sky Diabetes. So it seems a simple process, but I can tell you it hasn't really panned out that way for us. So
it doesn't even sound simple.
It makes sense, but so and it's so I'll share with you some of our experiences in delivering that. Oh, sorry, this is what it looks like now. This is what the clinicians see. So this is just an example. So this was the previous Sky Diabetes slide, and you can now see that they can click into a screenshot which brings up Diasend, and here you'll be able to see real-time data of that patient uploading their blood sugar readings. So it's instant. So that simple slide has taken a lot of work, but
Are the doctors willing to look at it?
absolutely, absolutely. Yeah. They see this as a fantastic resource for Scotland, and it's really been a real collaboration and a real effort. Decided to split this up into a few questions just to kind of keep the discussion going. So, key questions. So, is what we're doing in Scotland, is it a test or is it part of a larger rollout? Well, the quick answer really is it's both. So we're very fortunate in Scotland that we have a national and strategic telehealth care strategy, and that is clearly aligned and makes home health monitoring a key priority for our government to progress. And that, above all, has been such a help for us within United for Health. But saying that, we have a strong strategic focus, but really to make it happen, we need local implementation and clinical engagement. It won't happen on the ground if we don't make it happen. We're also, you can see, bringing together two existing national infrastructure kind of technology platforms, and what we're doing is linking them together. But to do that, it's a brand new technological solution we're creating. It's something very new, and the Diasend is a very new link for Scotland. And the plan really is that if this evaluates well in United for Health, patients like it, if there's an impact clinically, then we'll be able to see that as a national rollout across Scotland. So just a really huge lessons learned around for us in Scotland. Having a national and strategic policy really does add strategic value, as it really sets the parameters for change. So what are we all aiming for? What is the direction we're moving in? And also towards our shared outcome. What do we need this to achieve? So it's really helpful. So have we had to redesign service delivery? Absolutely. So it's a new IT solution, as I've said, and we've tried to canvass our United for Health boards to be early pioneers of this. So acknowledging it's new, and acknowledging there's a risk, an element of risk to this, but also our ambition about what the future possibilities of this initiative programme could actually mean for Scotland. So what we're aiming for is a centralised rollout across 3 geographical areas in Scotland. We are balancing at all times the realistic project goals of each stage. So each area is at a different stage in the process. We're balancing local capabilities and their climate for change. And it has taken quite a bit of time, but I think it's been invaluable to do, and it's actually been a necessity to do. So we've absolutely, from the outset, involved a huge range of stakeholders, and this has really been a purposeful effort on our behalf to be inclusive and really to make this change happen. But I'd certainly say, probably of no surprise, our most challenging area has been our clinicians and some of our senior clinical staff. And I don't really think it's about the concept of telehealth or what we're aiming to do isn't supported. It is very much, but it's very much that often there's this conflict between what are strategic priorities and what are the local priorities. And often some of the researchers aren't interested in this particular part at this particular time. So often it can be trying to negotiate and discuss around how that can be addressed. So essentially it is a new product, so it's untested. We've had to develop this from start with the university colleagues in Dundee. And so there is an element of risk. When will it be ready? How will it happen? What if it doesn't work? What's your plan B? What does this mean? So there's always lots of questions. So at all times, I think it's been really important for us to manage expectations around what we're expecting. And also there's a key question about, the exit strategy, what will happen at the end? What are the outputs? What are we expecting? So we've been really open and transparent with our partners about, this is a process we're in together, so let's just make this change. So for me, just some key lessons learned around service redesign. It's really important. Our key role really has been to facilitate and enable local ownership of these changes. They're local problems and they can find the local solutions to it, but at all times not losing sight of the need for us to keep it moving. We have to keep progress going. And I think often it's perhaps a step in terms of service redesign that might be overlooked, but we certainly find that the pathway mapping, so what we are doing now to what we will be, has been really critical. And it's really been that time when we've been able to work with our clinicians around the problems it might potentially cause or have, understand the overall ambition of the project. But again, it needs time. But again, it's worth investing and not to be underestimated. And I think Claire brought up earlier about this idea about involving patients as early as possible. Absolutely. We've consciously taken that decision, and patients have been involved in our testing of the product. We also have a patient reference group who are looking at all the literature we're producing about the product so that they can have immediate access and feedback as to how relevant and useful it is for them. So how are we implementing? So we're describing it as a planned, complex service redesign approach because it is big. So we're planning it, but it's complex. And we've created a vision, we've created the scene, this is what we want to happen. We've engaged locally, and to be honest, we've listened. We've said, what do you need to make this happen? What will you need from us to kind of implement this? And I think, again, it's a really important fact, making change possible. We've really over-communicated, frequently communicated, really just keeping everyone up to date with what is practically happening with the project, how the changes, what are the timelines associated with the implementation of technology. We've invested in are investing in a lot of multimedia resources to make it look attractive for people to be involved, not just patients but clinicians. They see tools that help them, short video clips that make it easier for them to understand how it's going to be possible. This really does, I think, demonstrate that this product is here to stay and we want it to work, and I think it really does make that difference. We've, SETT have decided with this approach that we've really tried to streamline the procurement process of the DISM product. We've taken that on board ourselves. So we've undertaken the negotiation around, what this will cost, how it will look like, what business model we would hope to use. And we've undertaken that centrally, but we've actually asked our local partners to buy it. So they purchase it locally. So again, they have that local ownership. And really key for us has been evaluation. Every point of the project pathway has been around how are we doing, is it making the difference we thought it would be, and from all different ranges, not just about the technology, but also from patients and clinicians. So I think overall, a key lesson I feel with United for Health already is that we need to see it as a journey, not a destination. We are in that road. And we're still developing this product, and we don't have all the answers, and that's just part of where we're at with this, and I think that's okay. That's good. One of the most valuable pieces of work we undertook very early on in the project was to look at benefits realisation, so bringing all of our different components of the service together, so patients, clinicians, technology, people who operate our services, and getting them to have a shared agreement on what this would deliver for patients, what the outcomes would be. And I think that really got everyone talking together and really seeing what this could be, and also started the relationships and the networking, which is really important for change. And also, just lastly, we've really had to, I think, consider investing in learning for people who are leading these changes locally. So we have project managers who are working with local clinicians, and this necessarily hasn't just been in the technology, it's actually been more around the process of change, service improvement methodologies, how to deal with resistance to change, how to kind of manage the whole process. So I would say that my 3 top tips for that could be what we're focusing on today is one of the huge factors for us is really to ensure that the technologies have the functionality and flexibility to be delivered at scale and within the implementation timeline. We within United for Health have significantly underestimated the time it's taken to develop this product, and that is what has led to our delays. I think it was conceptual, and we perhaps were led to believe or felt that it would actually progress much quicker than it has. And it has from a technological standpoint, but you also have the business integration aspect to consider as well, so it's taken a lot longer. So be really clear from that from the outset, I think would be my top tip. And this concept of bringing people together, I mean, it's been fantastic for us. It's been critical to bring technology teams with our clinicians. As I said, the benefit realisation work was really helpful. We talked about impacts, and also we were able to agree solutions to make it happen on the ground. So it's okay having this vision up above, but we really need the local solutions to local problems. Delays in technology rollout, any slippage you have within your project, it really needs to be actively managed, and if possible, some kind of mitigation around it. So how are you managing that? Because certainly we have felt that as soon as you lose momentum with your project, or people lose trust in what you're trying to do, then you do risk losing your engagement with your clinicians. And you've worked so hard to achieve that. So it's really important, I think, to always be aware of that and to be proactive about how you manage that. So finally, I think, as very much embedded, I think the process of change is a journey rather than a destination, and that's perhaps where we're at. And it's really important to build in flexibility. You need to allow local variation for local fit within local services. It's about investing in learning for our clinicians and keeping them up to speed. And I think above all, it's about keeping patient care at the centre of that change, because this is really what we are delivering these services for. And it's really important that we're mindful of that. So thank you. Thank you.
Thank you, Michelle. I have one quick question just to ask. Does the diabetes, My Diabetes My Way, is it also targeting pre-diabetic patients or not? Not yet. I think the plan is they've started with the people who have a diagnosis of diabetes, and that is verified by clinical diagnosis and clinical staff. But thinking around long-term condition management, and you're looking more at preventative conditions and anticipatory care, there are plans to roll out this to be a much bigger platform, and then they can bring that into it. So this would be part of that. And presumably, because I know other things that are happening in Scotland, the patient that's considered to be pre-diabetic doesn't miss out completely, because you've got your wonderful Living It Up platform as well, yeah. Which is totally designed to help people keep well.
And we're linking My Diabetes My Way with Living It Up.
That was
we're getting
just
the connectivity.
Yes. Okay, brilliant.
So
Thank you,
yes.
Michelle.
In our case, we had a lot of time devoted to redesigning the clinical pathway. Who should do what between the cardiologist, our case was the congestive heart failure, the cardiologist, the primary healthcare doctor, the case manager, the nurse at hospital, the nurse at primary care, and that took us a lot of time. And who was taking time? Who was receiving the data from the patient, whether it was the cardiologist in the hospital, the primary healthcare doctor. The first 2 weeks would be one, the others. In what case, did you spend a lot of time on those redesigning of the clinical pathway? More even than with it, well, the integration was horrible. but in terms of discussion, it took us longer time, this kind of clinical redesign, more than the technical issues.
Absolutely, because we set up a structure to enable the change, so who would be involved, who would be the key decision makers, and then we had to wait on the technology so we could demonstrate it. So it's been incremental, and we've really had to, I think, have a tremendous amount of engagement, and we've set up local implementation groups which contain all those individuals. So we've brought together consultants, specialist nurses, GPs. So we've really worked hard at who gets together at which point. So it has been, as you said, really time consuming, but to me it wouldn't go anywhere if we hadn't done that. And it's part of it's almost like needing to take the clinicians with you on your journey as you progress through that. Because, as I think Jana picked up earlier, they do see themselves as quite unique. And I understand that, because they're historical services, they don't just radically change. And I think if you overlook those types of issues, then it'll come back to haunt you later, so to speak.
I've only one comment. I'm really happy that you talk the way you do about both barriers and possibilities. And this also gives me consolation with regards to our own pilot. But what I really see, what gives me the interest in staying on, is actually the way we see that we are pushing systems towards change. And you were just explaining the clinical part, and what we see in our project at this stage is that it's also about big organizations which are not prepared for projects. And but there is not a way back, and that means that we are pushing it towards something. They have to relate to. They actually can't deny, and that's what makes the project interesting.
Absolutely.
Slightly switching to the you have also provided quite interested insight in your technology, and it's really well designed. I have a question for this Diasend, because actually you said it actually popped up on your screen as an extra element. So do I suspect correctly that it's still not yet fully implemented? So you would have your SCI system, and the Diasend would somehow come up separately?
Yes. Sorry.
And would you, what are your plans for the future? Would the glucose values that come from the patient, they would remain earmarked as patient values, right?
Yes. I think to say at the moment, this is a Scottish word, clunky system. So it's very multiple sign-on situation. We've streamlined it as much as we can from the patient perspective, because we're very aware if we make it too complicated, we won't get the engagement that we need. But the clinicians are having to do a bit more work. So they're having to go into For example, the Sky Diabetes, they're then having to link on the DiaSend button, they're then having to put a password in, so it's not as streamlined as we would like. And I think that knowledge will come as our technology team at the university in Dundee. This is still quite new to them, and so I think we're in the cusp of something that could be quite exciting. And I think the more they want to really roll it out, so we can begin to see how we can have workarounds or possible different ways of looking at it. The actual DiaSend product isn't a new software. It's readily available in Europe. They're a Swedish company, but we've chosen that product because they have software that enable over 80% of blood glucose meters to be uploaded. So often you may have a software that only allows one. So how can we can't scale up a system when 14 different health boards in Scotland use different blood glucose meters. So we need something that's going to create that. So I'm not, and the DiaSend team are equally aware of the possibilities of this with us. So it's been a really exciting process. So.
And presumably the fact that it's clunky at the moment, is part of the journey to get some of your clinical users to start informing how they actually want that integration to look in the future. And until you get to the first step, you know, where people miss that step, you usually don't get the right product at the end anyway. So there's no right way of doing this, and often, certainly in the UK, we opt for this stepwise approach to integration.
And when we've spoken to some of the senior service managers, first step is, what will it mean for my patients? And it's almost like, so long term, what will happen? So they want to know immediately how this is going to be sustainable, who's going to pay for it. You know, so you have to really try and build a case for what it is new, and that's why we have to work with it. And I suppose that.
My question is somehow related to the discussion. Our experience, the medical doctors are not used to look at data just because data are there. So in most cases, there is a kind of warning when there are abnormal results for a patient. Are you thinking about something like that? Because in some countries, there is even a different problem. A GP in Germany or in Belgium is not paid for looking at the data. So they have an even bigger problem. They have to change the way they are paid. Mm-hmm. But even without forgetting about that, I think the medical doctor do not do that as a routine, looking at data of their patients. No. How can you obtain that in Scotland? Have you thought about it?
So I think we're seeing it as a kind of a phased approach. So we're launching the product, and the focus is largely on self-management, self-coaching. So it's really for our patients to be able to use the data. And then obviously it'll be available to all of our practitioners. And then we hope to be able to work with community teams, so diabetes teams, in terms of what the information means. Because there certainly is a view that doctors may see this information but won't do anything about it. And some services are already thinking ahead, which is quite exciting, thinking about how local areas could actually look at accumulative data from that area and then arrange groups or educational awareness sessions or look at how they might use all that. So I think there's lots of ideas about how it will look and feel, but I think it's very much around this idea that we need to start and then see what kind of appetite people have for it as well.
Okay. Thank you, Michelle.